Okay, so we're going to get started. Since it's 6 a.m., I have a lot to cover again. And in fact, I may even have more to cover in this session since we're covering things like preeclampsia, obstetric hemorrhage. So just like I said on Tuesday, I'm just going to keep going at quarter of. If I'm still going, I know you need to leave, and then you can just come back and look at the rest of the podcast if I don't get through all of this. So our first topic is anesthesia for C-section. For any of you who've been on OB, you know that generally regional anesthesia is our preferred technique in these patients because it avoids the risks of aspiration and difficult intubation, which are increased in pregnant patients. In order to do regional, to have adequate anesthesia, you're going to need anywhere from a T4 to T6 level. But there will be times when you can't do regional. You have a coagulopathic patient, maybe HELP syndrome with a platelet count of 20,000, sepsis, a patient in shock, and occasionally the patient who just outright refuses. As you know, you can't do a procedure on any patient who refuses that procedure. Now, in terms of doing regional anesthesia, if you're going to do that, the next thing you need to do is decide which technique am I going to use, an epidural, a spinal, a combined spinal epidural. So in what situation might you use each procedure? So in terms of epidural anesthesia, it's going to be preferred in situations where you want to know from second number one that you have a well-functioning epidural catheter. So for instance, a patient with a difficult airway. If the surgeons took longer and you had a single-shot spinal or even a combined spinal epidural and the spinal wore off before surgery was over, you wouldn't want to be in the situation of not being able to continue with your regional anesthetic. Even with a combined spinal epidural, rarely you'll have an epidural catheter fail. So in those patients where you really want to make sure that you have a very reliable epidural catheter, that's the technique you're going to start with to begin with. So someone with a difficult airway, someone in whom you think it's going to be a long surgery. You know, she's 400 pounds and this is her 5th C-section. Obviously, if they already have an epidural catheter in place for labor, that's what you're going to use if they go for C-section. And there may be some select situations where you really want to raise your level very slowly as a result of either maternal or fetal status. So for instance, the patient with cardiac disease, severe aortic stenosis, if you were going to consider doing regional in that patient, you want to very slowly raise that level so that you don't have a precipitous drop in SVR. So that would be a place where you would use an epidural. And another would be if you have a baby where you know it's not going to tolerate any decreased uteroplacental perfusion due to hypotension that you cause. Again, you may want to very slowly raise your level to avoid that. And epidural would be the technique of choice in those situations. Now, in terms of epidural, here's a question. Which statement about the use of epidural 2-chlorprocaine for C-section is most likely true? That it enhances the efficacy of epidural morphine. It's contraindicated when late fetal heart rate decelerations are present. The risk of systemic toxicity is increased in a woman homozygous for atypical plasmacholinesterase, or the EDTA present in some formulations causes neurotoxicity. So I saw one person put their hand up for letter C, which is correct. So chlorprocaine is metabolized by plasmacholinesterase. So you could see increased risk for toxicity because they will not metabolize the drug as quickly. In terms of epidural dosing, as I said, you need anywhere from a T4 to T6 level. In non-emergent situations, generally lidocaine is going to be your drug of choice, but because we talked the other day, chlorprocaine is going to be preferred in emergent situations. Number one, because it has a more rapid onset, so you're more likely to get a block quickly enough for them to be able to get surgery started and avoiding general anesthesia, but also the fact that in emergent situations, you very well may have an acidotic fetus, and so you avoid that issue of ion trapping that we talked about the other day. In terms of additives, you can add epinephrine to your epidural to increase both the density of the block and prolong the duration, and you can add sodium bicarbonate to speed the onset. Now, spinal anesthesia is going to be your regional anesthesia technique of choice for C-section when you are in a situation where you want a rapid onset. So maybe it's the patient that's come in, she's 8 centimeters, and they've just discovered it's a footling breech, and they want to get the section started very quickly before she tries to deliver a footling breech vaginally. That would be a situation where you would want to do a spinal anesthetic. The other things to keep in mind in terms of advantages of spinal is that you do get a denser block than with an epidural. But as I said before, with a single shot spinal, you don't want to use it in situations where you may have a difficult airway, or there's some reason that you really want to avoid general anesthesia, or that you expect there'll be prolonged surgery and the spinal might not be adequate for the entire surgery. In terms of combined spinal epidural, the nice thing about this is that it provides both the benefits of spinal, so you get a more rapid onset, you get a denser block, but the versatility of an epidural because you have the epidural catheter in place. However, as I said, rarely that epidural catheter can fail even when you get an adequate spinal block. And so I personally don't recommend using combined spinal epidural in those situations like a difficult airway, maybe a patient with a history of MH that you absolutely would want to avoid general anesthesia, or if you think it's going to be a long surgery. Now, as we said, there are going to be times when you need to do a general anesthetic for C-section. A patient is hemorrhaging, or they are septic, something like that, where they would not tolerate well a significant sympathectomy from neuraxial anesthesia, or situations like fetal bradycardia. The heart rate's been down now for 5, 6, 7 minutes. They want to get this baby delivered as quickly as possible. Clearly, inducing general anesthesia is going to be quicker than putting a spinal or an epidural in a patient, unless they happen to already have an epidural catheter in place. Special concerns with the OB patient, of course, is that we know that these patients are at higher risk for failed or difficult intubation, and they also are at risk for aspiration. In terms of management of general anesthesia for C-section, always make sure they get a non-particulate antacid. As you're getting everything else ready, you can shout out to a nurse, has she had Bicitra? If not, you designate someone to do that, to get it and give it to the patient. Left uterine displacement is important in these patients. Adequate pre-oxygenation. One good thing because of the increased minute ventilation is that you can adequately pre-oxygenate more quickly in an obstetric patient than a non-obstetric patient. And then because they are an aspiration risk, it would be a rapid sequence induction. So here's another question. Which statement about the management of failed intubation after induction of general anesthesia for emergency C-section is most likely true? A, the patient should be awakened regardless of fetal status. B, if mask ventilation is easily achieved, mask ventilation with cricoid pressure should be maintained throughout surgery. C, if mask ventilation cannot be achieved, an LMA should be inserted. Or D, transtracheal ventilation is not appropriate in a parturient. So the correct answer would be C. In terms of B, you may potentially, if it's fetal distress, continue mask ventilation with a cricoid until baby's delivered, but at that point you would want a more secure airway. You can do transtracheal jet ventilation in a parturient. You would not want to delay delivery of the baby by waking up mom if you had severe fetal distress, but clearly you need to ventilate this patient, so you can place an LMA if you're unable to mask ventilate. And generally what's recommended if you have to use an LMA is, in order to get it to seed correctly, to release your cricoid as you're placing the LMA, but then place cricoid back once the LMA is in place to help prevent aspiration. So in terms of, I guess I've already answered most of these questions from this slide, but one thing is, if you are, for instance, doing a general anesthetic in a non-emergent situation, maybe it's a patient who refused regional anesthesia. In that situation, it actually would be suggested, if you can, to just wake up the patient and then go another route, either to secure the airway while awake or to consider a regional anesthetic if the patient would allow that. In terms of maintaining general anesthesia before delivery, most of us will use a mix of 50% nitrous, 50% oxygen, along with anywhere from a half to 1 mac of volatile agent. 50% oxygen is what you want to maintain. Generally, if you have a mother who is oxygenating normally, going above and beyond 50% FiO2 is not going to significantly increase the amount of oxygen delivered to the fetus. So you can continue to use that nitrous oxide. Now, after delivery, one of our concerns is the effects of our anesthetics, specifically our volatile anesthetics, on uterine tone, because once baby has delivered, we want that uterus to contract down. So generally, we will decrease our volatile agent to about half a mac, and then start giving IV opioids, and we can also increase the concentration of our nitrous oxide to make up for that decrease in volatile agent that we are doing. So that is usually the typical way to maintain general anesthesia in these patients. If you have a patient with decreased uterine tone, and even with your volatile agent down to half MAC or less, there's still concern about uterine atony, you may at that point in time actually consider turning off your volatile agent and using a TIVA. This is a nice question that they sometimes like to address on the in-training exam, is the effect of pregnancy on the uptake of volatile anesthetics. So the thing to keep in mind is that the rate of rise of alveolar concentration is going to be increased due to those physiologic changes in pregnancy, being specifically that there's an increase in minute ventilation and a decrease in functional residual capacity. Now, if you remember what affects your uptake, you might also say, well, but there's also an increase in cardiac output, which actually will slow the rise of alveolar concentration. And that is true, but the combination of the decreased FRC and the increased minute ventilation is greater than the effect of that increase in cardiac output. So, in fact, inhalational induction would be faster in pregnancy. Clearly, you wouldn't ever really do that because she's a full stomach, but in terms of testing your knowledge about uptake, the answer would be that in pregnancy you will have a faster inhalational induction. Sometimes there will be questions related to the effects of general anesthesia on the infant. So, thiopental, I'm actually going to skip over this slide because I think it's been far enough out now that thiopental is not available in this country that they will hopefully not ask that, but it's there for you to look at in case you want to. In terms of nitrous oxide, it readily crosses the placenta, and fetal levels will equilibrate with maternal levels after prolonged exposure. As a result, until delivery of the baby, we generally don't want to increase our concentration above 50%. We talk about induction to delivery time as well as uterine incision to delivery time. It's been shown that if your induction to delivery time is less than 15 minutes, that there'll be less of a depressant effect on the neonate. And that's one of the reasons why when we do general anesthesia in OB, we don't induce anesthesia until the patient's prepped, draped, and the surgeons are ready to start, so that we minimize that induction to delivery time in terms of the effects on the baby. In terms of our halogenated agents, they do easily cross the placenta and will rapidly equilibrate with fetal tissue, so that you can see some neonatal depression from your volatile anesthetics, but with a rapid delivery, which is what we generally see, there's not generally a significant effect. When you look at neonatal APGAR scores, the only difference you will see in terms of studies between general and regional is a decrease in the 1-minute APGAR, but by 5-minute APGAR you don't see any difference in terms of neonatal outcome between general and regional. So a patient is receiving general anesthesia with desflurane and nitrous oxide for an emergency C-section. Which statement about the effects of general anesthesia on uterine tone is most likely true? So A, nitrous oxide will decrease uterine tone. B, oxytocin-induced uterine contractions will be unaffected by desflurane. C, desflurane will decrease uterine tone to a lesser extent than sevoflurane. Or D, the effect of desflurane on uterine tone is the same in pregnant and non-pregnant state. So the answer is actually going to be D. So your halogenated volatile anesthetics do decrease uterine tone. Desflurane has less inhibitory effect than other agents, but all of them will have some inhibitory effect, and that's why we try to maintain our MAC at 0.5 or less. The uterus does still respond to oxytocin, but in a dose-dependent effect, and once you get up to about 2 MAC of volatile agent, you can give as much oxytocin as you can just pour it in, and it won't have an effect. But it is your volatile agent's effects on uterine tone is dose-dependent. So those are things to keep in mind. In terms of other effects of anesthetics on uterine tone, ketamine, just to keep in mind that in larger doses, greater than 1 milligram per kilo, so if you perhaps were considering using ketamine for your induction agent for a C-section, will increase your uterine tone. So generally, I like to avoid ketamine as my induction agent in situations where I may have uterine hypertonus, and that would be primarily and specifically placental abruption. So in that situation, a bleeding mom with uterine hypertonus from a possible abruption, I would choose etomidate over ketamine because of the effects that ketamine may have on uterine tone. Uterine incision to delivery time is an important thing to understand. What we know is that once the surgeons do make their incision into the uterus, that now begins to interfere with normal uteroplacental perfusion. And can result in decreased uteroplacental perfusion. And what is the conventional teaching is that once your uterine incision to delivery time extends beyond 3 minutes, you have a greater risk of neonatal depression as a result of that. And that is why the obstetricians, once they make their uterine incision, try to get the baby delivered as quickly as possible. Here's another case to look at. You have a woman who's taken to the OR, and we're now moving on to uterine relaxation, manual extraction of the placenta. So you have a woman taken to the OR for manual extraction of a retained placenta. Her blood loss has been 500 milliliters, and her vital signs are currently stable. She has an epidural in place, which was dosed with lidocaine to get a T10 sensory level. She's comfortable as the obstetrician goes up and tries to manually extract the placenta, but as he does that, he tells you that the uterus is clamped down and he needs uterine relaxation in order to be able to effectively extract the placenta. Which of the following is the best technique to provide uterine relaxation in this patient? A, an IV nitroglycerin bolus, B, IM methyl-orgonovine, C, a high concentration of desflurane after tracheal intubation, or D, epidural lidocaine to increase your sensory level. So I saw a couple people say A, and that would be correct. Methyl-orgonovine is actually going to increase uterine tone. You could use your volatile agent, but that's going to take a lot longer. It involves having to induce general anesthesia, and your sensory level is not, with your epidural, is going to have no effect on your uterine tone. So in terms of methods for uterine relaxation, nitroglycerin is what we generally prefer to use. It's a potent smooth muscle relaxant. And the reason that we prefer it is that it has a very rapid onset, and also very importantly, it has a short duration of action. You give it within seconds, the obstetrician will tell you, I can feel the uterus relaxing. Once they get that placenta removed, very quickly that you will be able to give oxytocin and have the uterus contract back down. Because in most situations where you need uterine relaxation, once you, for instance, have delivered the placenta, now you need the uterus to contract down. With your high concentration of volatile agents, in addition to having to induce general anesthesia and intubate the patient, it won't go away as quickly. So those are the reasons. People sometimes worry about hypotension. Actually, significant hypotension with a 100 mic bolus of nitroglycerin is very unusual, and even if it occurs, it's very easily treated and will last very briefly. In some situations, though, maybe the nitroglycerin is inadequate for the amount of relaxation they need. In that situation, then you can use your volatile agents. As I said, it causes a dose-related relaxation of uterine smooth muscle. And so with 1 MAC of most of your agents, you'll see about a 50% decrease in the contractile response of the uterus. But the problem is, because these patients are full stomach, you need to intubate the patient. You can't just put a face mask on and turn up your volatile agent to get your uterine relaxation. So next we're going to move on to preeclampsia. So one thing to be aware of, and to be honest, I'm not sure if the in-training exam is going to be this up to date or not, but over the last couple of years, the definitions of preeclampsia have changed. So it used to be that you had to have a systolic blood pressure 140, diastolic of 90, and proteinuria of over 300 milligrams per 24 hours. If you have those 2 criteria, you still have preeclampsia. However, they now say that you don't have to have the proteinuria. If you have that blood pressure and any of these others, thrombocytopenia, elevated liver transaminases, elevated serum creatinine, mom has developed pulmonary edema, or she's having visual or cerebral disturbances, even without the presence of proteinuria, that now gives you the definition of preeclampsia. The other thing that has changed is that they are now discouraging the use of mild preeclampsia, and they are using either just preeclampsia or preeclampsia with severe features. And the severe features are pretty much the same as what they were in the past. Blood pressure 160, systolic, diastolic 110, the presence of thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, cerebral or visual disturbances. The one thing they have removed from the definition of preeclampsia with severe features is they used to also look at the placental organ and the fetus, and if the mom had IUGR, that put her into the severe range. They have removed that from their definition of preeclampsia with severe features. Also realize eclampsia is when you have preeclampsia along with the presence of seizures, and your HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. So that's a subset of preeclampsia. In terms of the pathophysiology of preeclampsia, the etiology is still not really well understood, but we do know for certain that somehow it involves endothelial damage within the placenta, and as a result of that damage, there's release of placental vasopressor activating substances, such as there's an increase in endothelin levels. You have a change in your thromboxane to prostacyclin ratio, so that you have an increased level of thromboxane, a decreased level of prostacyclin, and as a result of that, you have a promotion of generalized arterial or vasoconstriction, as well as platelet aggregation, and that's what leads to this being a disease of vasoconstriction, and the fact that we also can see problems with thrombocytopenia and decreased platelet function as a result of that platelet aggregation that can occur. But the main thing to know is that we do know it's endothelial damage within the placenta, and we have increased endothelin levels and a change in our thromboxane to prostacyclin ratio. So you have an otherwise healthy woman at 33 weeks gestation who's been diagnosed with severe preeclampsia, which is defined as most likely a sign that she has compromised renal function due to her preeclampsia. A serum creatinine of 1.1, a uric acid of 2, a BUN of 5, or a transaminase level of 100. So, of course, the answer would be creatinine of 1.1, and so the reminder again that in normal pregnancy, although you might say a serum creatinine 1.1 is within normal range, in pregnancy, because of the increased GFR, a normal creatinine is about 0.5 to 0.6. So she's showing that she has an elevated serum creatinine. You can see elevated uric acid levels in preeclampsia also, but 2.0 is not elevated. And transaminases obviously won't have anything to do with renal function, but that would be a sign of severe preeclampsia to have an alanine transaminase that high. In terms of the effects of preeclampsia, concerns for us on the airway is that you may see even more airway edema than in a normal pregnant patient, so there may be an even higher risk of difficult intubation. In terms of cardiovascular effects, we see that their SVR is increased. This makes sense when you think about it being a disease of vasoconstriction. They do generally have a decreased circulating volume, so they are overall generally intravascularly depleted. They do have an increased sensitivity to vasopressors, so I generally will not give more than 50 mg of phenylephrine at a time, or 2.5 milligrams or 5 milligrams of ephedrine. They have, in most cases, you'll see an increase in cardiac output, and these patients are at risk for developing pulmonary edema, and that is usually a combination of three things: their increased SVR, their leaky capillaries, essentially they have decreased capillary membrane, they have increased capillary membrane permeability, and we may fluid overload these patients. That is the major cause of pulmonary edema. Occasionally you'll have patients with severe preeclampsia, in which is actually a component of left ventricular dysfunction, which can be the etiology of pulmonary edema also. In terms of CNS, our major concerns are seizures, cerebral hemorrhage, and cerebral edema. A major cause of maternal mortality in women with preeclampsia is a cerebral bleed. So to keep that in mind, and that's why we need to be careful about maintaining blood pressure and treating significant hypertension. These patients can have a decreased GFR and can develop oliguria from the renal standpoint. hepatic standpoint, we oftentimes see the increased liver enzymes, but also be aware that these patients, the very sick patients, can absolutely have subcapsular hematoma, and I've seen in my career once an actual hepatic rupture that ultimately resulted in maternal death. Hematologically, our major concern is that these patients have thrombocytopenia. And the other thing to remember is that we talked with physiologic changes of pregnancy that you see a rightward shift of the oxyhemoglobin dissociation curve in pregnancy. In the preeclamptic patient, it shifts back to the left, so it goes back to about where you would see it in a non-pregnant patient. So this affects oxygen delivery to the fetus, and one of the reasons why these babies are at higher risk for fetal distress and developing fetal hypoxia. Clearly, we see decreased uteroplacental perfusion with preeclampsia, so more likely to have an emergent C-section. Also, as a result of the placental unit not working as well, we also are more likely to see IUGR. Now, we have a woman who presents to labor and delivery at 27 weeks. She's got a headache. Her blood pressure is 185 over 115, normal heart rate. Urinalysis shows that she has 4+ protein. So essentially, she has preeclampsia with severe features. And which of the following is the best medication to treat her hypertension? Magnesium sulfate, labetalol, esmolol, or lisinopril? So the answer would be labetalol. Number one, magnesium sulfate, although it can cause transient vasodilation and you may see small transient decreases in blood pressure, is not meant to treat blood pressure. It's used exclusively to prevent seizures and preeclampsia. Esmolol is a pure beta blocker, whereas labetalol is a combined alpha beta. And the advantage of that is that with your pure beta blockers, you actually can see some fetal bradycardia. And specifically with esmolol, at least in pregnant sheep, it's been associated with fetal hypoxia and acidosis. And lisinopril, being an ACE inhibitor, those are contraindicated in pregnancy. In terms of obstetric management of preeclampsia, we all know that the teaching is definitive treatment is delivery, but with early preterm, they will try to maintain the pregnancy if they can, as long as mom is not too sick, at least to have time to give steroids. Magnesium is generally used for seizure prophylaxis, and labetalol and hydralazine are the most commonly used drugs to treat hypertension in the preeclamptic patient. Which statement about the effects of administering magnesium sulfate to a patient with preeclampsia is most likely true? A, sensitivity to non-depolarizing muscle relaxants is decreased. B, platelet aggregation is increased. C, the risk for postpartum uterine atony is decreased. Or respiratory depression may occur if a serum magnesium level is greater than or equal to 12. So this brings up knowing about your magnesium. So let's look at magnesium levels. So your therapeutic range is going to be anywhere from 4 to 6 milliequivalents per liter. You can start seeing some EKG changes at levels of 5 to 10, a prolonged PR interval, a widened QRS. At about 10 milliequivalents, you'll see deep tendon absent or decreased deep tendon reflexes. You can see respiratory depression at a level of about 15. SA and AV node block will also occur there, and you will see cardiac arrest at 25 milliequivalents per liter. But it will actually, let me go back there in terms of that. So, but platelet aggregation can be increased with your magnesium. So other things to keep in mind in terms of the effects of magnesium. It does, in preeclamptic patients at least, with magnesium sulfate, you will see an increase in uterine blood flow, so it can help some with your uteroplacental perfusion. It does, as you can know, going to decrease uterine tone. That's why it's also used sometimes as a tocolytic. It does have an effect on your neuromuscular function. It decreases acetylcholine release. It decreases motor end plate sensitivity to acetylcholine, so it increases sensitivity to all of your muscle relaxants, both depolarizing and non-depolarizing. Although I would tell you that I would not decrease my succinylcholine dose in a situation of induction in a patient on magnesium, because you can't really predict how much it's going to affect your muscle relaxant. And the most important thing when you are inducing general anesthesia in these patients is to have good intubating conditions so that you don't have difficulty with intubation and with struggling with the airway, that you don't increase mom's blood pressure. So with succinylcholine, it's so short acting that even though magnesium is going to prolong it, it's clinically generally not going to be significant when you're doing a C-section. It's only going to be by a few minutes. So I give my full intubating dose of succinylcholine so that I know I have good intubating conditions. On the other hand, with non-depolarizers, I will start out with a smaller dose if I'm going to give some non-depolarizer to maintain neuromuscular, to maintain muscular relaxation after induction of my general anesthetic. Placental transfer can result in some neonatal respiratory depression, especially if you're have a higher level than you really want in mom, maybe because she's developed some renal dysfunction. And so these babies may be somewhat floppy with poorer muscle tone if they've been on magnesium. In terms of anesthetic management with preeclampsia, labor analgesia, generally we prefer to have an epidural in these patients. First of all, we know they're at higher risk for an emergent C-section. If we have an epidural in place, then we can use it. We can avoid general anesthesia if they do need the C-section. It's also been shown that with epidural analgesia, it decreases maternal catecholamine levels, so it may help to some extent with blood pressure management in the mom. And it's also been shown in preeclamptic patients to improve uterine placental perfusion. The one concern, though, is to be aware that you are developing a sympathectomy, that you can see hypotension develop, and the baby will not tolerate that. Now you have a patient with severe preeclampsia who needs a C-section due to a breech presentation. Fetal heart rate's normal. Her platelet count is 89,000, and it was 92,000 a day ago. Her blood pressure is 152/93. So which statement about anesthetic management of this patient is most likely true? A, that general anesthesia is your technique of choice. B, that epidural anesthesia is contraindicated. C, that the risk of spinal-induced hypotension is less in this patient than in a normal tensive patient. Or D, that the treatment of hypotension is not indicated until her systolic pressure is less than 100. So the answer would actually be C. So with a platelet count of 89,000, it's been relatively stable. There's very few OB anesthesiologists who would avoid neuraxial anesthesia. So epidural is not contraindicated. General would not be your anesthetic of choice. As you know, in terms of treating hypotension in these patients, you want to base it on their baseline. So generally when you get about 20 to definitely 30% below baseline, you start treating that blood pressure. So that would not be less than 100. Although in the past people worried about the risk of hypotension from your spinal, there are studies now showing that normal-tensive women are more likely to develop spinal-induced hypotension than patients with preeclampsia. So as mentioned, epidural is often preferred. It avoids general anesthesia. You can raise up your level, avoid any hemodynamic changes. Spinal anesthesia, though, is another good option. As I said, this concern about hypotension really is not, it's less likely to be a concern in the preeclamptic patients. And so there's no reason to avoid spinal anesthesia. I think for all of you, that's traditional teaching. Back in my day when I was a resident, we were actually taught to avoid spinal anesthesia in preeclamptic patients because of concern about precipitating significant hypotension. There will be times in these preeclamptic patients, though, where they do need general anesthesia, most commonly because of a HELP syndrome, a very low platelet count, or that you have severe fetal distress. In terms of managing these patients with preeclampsia with general anesthesia, you need to carefully assess their airway. If you have concerns about significant airway edema that it may be difficult to intubate, then you need to consider doing an awake intubation. If you have time, it's not severe fetal distress. One of your big issues in these patients is avoiding severe hypertension, so you might consider placing an arterial line. Generally, you want to do something to pre-treat before laryngoscopy to prevent hypertension, so that may be with an antihypertensive drug like some labetalol. It could be with a short-acting opioid such as remifentanil. As I mentioned, you do want to use your normal dose of succinylcholine, but reduce non-depolarizing drugs if you give those after induction. Now let's move on to a topic we don't talk about much, but it's been on the keyword list in the past. So that is, you have a patient with antiphospholipid syndrome who presents for repeat C-section. She's had a PTT that was prolonged at 50. All her other lab values are normal, including her PT, her fibrinogen, and her platelet count. She's not received any recent anticoagulation therapy. So which statement about her perioperative management is most likely true? That regional anesthesia is contraindicated because she's got that elevated PTT, that she should get FFP before you start surgery, that you should give vitamin K before you start surgery, or that low molecular weight heparin should be initiated in the postoperative period. So I see people shaking D, and that is correct because actually with antiphospholipid syndrome, these patients are at increased risk for DVT and PE. So what do we know about antiphospholipid syndrome? It's a prothrombotic disorder, and oftentimes these patients have been on anticoagulants during their pregnancy. And they have the presence of either an anticardiolipin antibody or a lupus anticoagulant. They about 25% of them of venous and arterial thromboses that occur in pregnancy occur during pregnancy. So these women, they are hypercoagulable and then they're pregnant, so it's a double whammy. So they are at significant risk for PE, etc. So they will, as I said, often be on anticoagulants. They also have an increased risk of fetal loss, especially during the second and third trimester, so they are high-risk patients. The thing to understand is that lupus anticoagulant has no anticoagulant activity, but it does result in a prolonged PTT if you send that to lab. But it's really like a lab artifact. It does not preclude neuraxial anesthesia. So unless they've recently been on anticoagulants, even with a prolonged PTT, there's no reason in the patient with antiphospholipid syndrome to avoid neuraxial anesthesia if they come back with an abnormal PTT. And as I said, most of these patients will be on either prophylactic or sometimes, if they've developed a DVT in pregnancy, therapeutic low molecular weight heparin. So let's move on to placental, to bleeding. So major causes: placenta previa, abruption, uterine rupture, and then in terms of postpartum hemorrhage, uterine atony, retained placenta, placenta accreta, and uterine inversion are all our concerns. So you have a 19-year-old woman at 33 weeks gestation who presents to L&D with vaginal bleeding and abdominal pain. Uterine activity monitoring shows that she has tetanic contractions. What is your most likely diagnosis? And the answer would be placental abruption C, because of those tetanic contractions. That's associated with that. Now, placenta previa, as we know, placenta lies over the cervical os. It can be complete, partial, or marginal. Generally, traditionally, painless vaginal bleeding. These patients will require cesarean delivery. In terms of management of these patients, or any of these patients with potential for obstetric hemorrhage, large bore venous access, make sure they have a type and cross, not just a type and screen. Your anesthetic technique, with placenta previa, they in some situations will require general anesthesia. If they're severely hemorrhaging, mom's hypotensive, or baby's in distress as a result of that. But if you have a patient with just mild to moderate bleeding with a previa and they're deciding to do a C-section, in those cases you may be able to use regional anesthesia. Clearly the patient coming in for a C-section for previa who's not actively bleeding, you certainly would do neuraxial. But if you're going to do general anesthesia, you want to use an induction agent that's going to maintain hemodynamic stability in this bleeding patient, so etomidate or ketamine. So as I said, there are indications where you clearly can use regional anesthesia with a placenta previa. Now, a placental abruption is where there's a premature separation of generally a normally implanted placenta. The difference between it is that they commonly will have abdominal pain. They will usually have vaginal bleeding, but unlike a previa where you'll always see it, in about 15% it can be concealed because instead they develop bleeding with a retroplacental hematoma. The increased uterine tone, and you're more likely to see fetal distress and even IUFD with an abruption than with a previa. And remember that abruption is the most common cause of DIC in pregnancy. So your plan with these patients, if it's mild or moderate, you need to decide to figure out what the OB's plan is. Sometimes with a mild abruption, they'll let them deliver vaginally. As long as their coags are normal, you can do an epidural in those patients. With a severe abruption, usually you're going to see signs of fetal distress or maternal instability. So this is where you're going to be doing an emergent C-section. You want to, again, have good IV access, have blood immediately available. Usually you're going to need general anesthesia. And as I mentioned before, for your induction, in this case, I would probably avoid ketamine because of its possible effect on further increasing uterine tone. Now, this has definitely been a question on the IT in the past. The most common sign of uterine rupture during VBAC attempt is A, abdominal pain, B, vaginal bleeding, C, recession of the fetal presenting part, or D, fetal bradycardia. And the answer, actually, a lot of people think it's pain or it's vaginal bleeding, and it's actually abnormal fetal heart rate. So the answer would actually be D. So in terms of uterine rupture, any patient who has either any sort of previous C-section or uterine scars, increased risk. As I said, fetal bradycardia, you can see in a smaller percentage of patients, though, the other signs that we've, vaginal bleeding, abdominal pain. Essentially, same thing, potential for bleeding, good IV access. Generally, if it's a catastrophic rupture where you actually have uterine contents sitting in the belly, you're going to need to do a general anesthetic. Sometimes you can have just sort of uterine dehiscence where the scar is separated, but you don't have any uterine contents out within the abdomen. In those cases, mom may be stable and baby may be looking okay, and you could use regional anesthesia. You always need to be prepared in these patients, though, to go to hysterectomy or definitely uterine repair, if not a hysterectomy. Now you have a gravida-4 para-3 woman with placenta previa, presents for C-section, hasn't had any recent vaginal bleeding, blood vital signs are normal, hematocrit's normal. She's had 2 prior C-sections, so appropriate management of this patient will most likely include A, getting a pre-op fibrinogen level, B, utilizing intraoperative blood salvage throughout surgery, C, preparing for massive transfusion, or D, administering single-shot spinal anesthesia. So what you need to know here is that she's got the red flag for Placenta Accreta because she's currently got a Previa and she's had 2 prior C-sections. So although she's not currently bleeding at delivery, she is at risk for major bleeding, so you want to prepare for massive transfusion. So these patients generally aggressive fluid therapy, and they may require blood replacement, oftentimes have hysterectomy. Most of us in these cases would do general anesthesia if we think they're at high risk for accreta or percreta. Next, uterine atony, most common cause of postpartum hemorrhage. As you can see here, a long list of patients who are at higher risk for postpartum hemorrhage, although many people who develop postpartum hemorrhage don't have any risk factors. So you have a gravida-5, para-5 woman, has a history of asthma, now has postpartum hemorrhage due to uterine atony. Blood loss is 500, she's still bleeding. Uterine massage has been unsuccessful, she's currently hypertensive. Most appropriate management at this time would be either IM methylorgonavine, IV oxytocin, IM hemabate, or uterine artery embolization by an interventional radiologist. So the answer would be the first thing you're going to do, your first line drug is going to be oxytocin. In this patient with hypertension, you'd prefer to avoid the methogen. She's got asthma, so you'd prefer to use the hemabate. If your other treatment doesn't work, you actually would consider uterine artery embolization, but the first thing is oxytocin. Now you have a healthy parturient who inadvertently receives an IV bolus of 20 units of oxytocin after delivery of the placenta. Which of the following is the most likely adverse effect? Bronchospasm, hypertension, hypotension, or pulmonary edema. So it's hypotension. A big bolus of oxytocin will cause vasodilation and hypotension. So in terms of pharmacologic treatment of uterine atony, oxytocin causes vasodilation. Boluses of 5 units or greater can cause hypotension. Methogen, the major concerns are that it can cause hypertension, and you especially can see severe vasoconstriction if it's given IV, so it should be given IM. Hemabate, the biggest concern is bronchospasm, relatively contraindicated in patients with asthma. You can also see some hypertension with hemabate also. Other aspects of management of uterine atony, of course, fluid blood resuscitation. You may see the obstetricians using a Bakri balloon that is essentially going to be like a tamponade effect. And then if all that fails, then you may have to go to more invasive techniques, such as a B-Lynch compression suture, uterine artery embolization, ultimately hysterectomy. If you're reaching that point, you've had significant blood loss, and you're probably going to need to do these procedures under general anesthesia. Amniotic fluid embolism, rare but fatal, mortality anywhere from 50 to 80%. In order for you to have an amniotic fluid embolism, though, you have to have rupture of amniotic fluid, amniotic membrane. So you're not going to see it in someone whose membranes are still intact. And there needs to be some sort of site of entry into the maternal circulation. But you can have little tears in the cervix, whatever, when someone's laboring. So anyone in labor, you can see that in. So how does it present? Generally, all of a sudden, dyspnea and a sudden drop in oxygen saturation, and then from there, quickly, cardiovascular compromise. If they survive that initial part, the first 20 to 30 minutes, then over time they can develop other problems, including DIC and left ventricular failure. So initially, you have the amniotic fluid enters into the pulmonary circulation. It's not actually a true embolism like a clot, but rather it causes a vasospasm. It's more of like an anaphylactic reaction, which leads to essentially sudden pulmonary hypertension, cor pulmonale, and then over time you can develop that left ventricular dysfunction. They'll have a deranged ventilation perfusion ratio, and about 40% of them will develop DIC. They also, on top of everything else going on, they're at a higher risk for uterine atony. So on top of the fact that you're dealing with the AFE, you may have uterine atony and bleeding related to that. So essentially, there's no curative treatment for AFE. It's all supportive, intubation, ventilation, aggressive resuscitation. Now, last thing, and I know y'all have to go, so go when you do. Just cardiac disease. As I said, I'm supposed to cover so many things in such a short period of time. But you have a woman with mitral stenosis, develops hypotension following induction of epidural for C-section. Which is the best drug to treat her hypotension? Dopamine, ephedrine, epinephrine, or phenylephrine? So the answer would be phenylephrine, because in these patients with stenotic lesions, you do not want them to be tachycardic. So I'm just going to briefly go through the four major valvular diseases and how you would manage that. So mitral stenosis, your goals in these patients are to maintain a slow heart rhythm with a normal sinus rhythm. They don't do well with any sort of AFib or whatever, so you have to aggressively treat that if they develop it. You want to maintain venous return as well as maintain an adequate SVR, as well as avoid anything that leads to increased pulmonary vascular risk resistance. So you need to treat their pain. So generally you will, if they're laboring, you'll use an epidural, but you have to be very slow and gentle about it so that you don't quickly drop their SVR, but they won't do well if they're in pain or if they become hypoxemic or hypercarbic. What about mitral regurg? In these patients, you want to maintain a normal to slightly increased heart rate. Again, you want to maintain sinus rhythm. You want to prevent any significant increases in SVR or your central vascular volume, but you do need to maintain venous return. You want to, again, avoid situations that increase pulmonary vascular resistance. Patients who are pregnant generally do well or better with regurgitant lesions because they do actually have a decrease in SVR as a result of the physiologic changes of pregnancy. And actually what we do with epidurals and decrease it further actually can be beneficial with that decreased SVR. It helps with your forward flow. So they generally do better. It's the patients with stenotic lesions that are usually more of an issue. Aortic stenosis, maintain a normal heart rate and sinus rhythm. You have to maintain adequate SVR and intravascular volume and venous return. And generally, you want to avoid any sort of myocardial depression, especially with your general anesthetics. Be aware of that. And then finally, aortic regurg, you want to maintain normal to slightly increased heart rate, prevent increases in SVR, and also you're concerned about myocardial depression during general anesthesia. Cardiac dysrhythmias, there's an increased frequency of cardiac dysrhythmias in pregnant women because of that atrial stretch that's occurring. SVT is most common. Most antiarrhythmic drugs, including adenosine, can be given safely during pregnancy. One to avoid, though, is amiodarone because it's associated with adverse fetal effects. So generally, you'll only use that if the patient is refractory to everything else. One thing to keep in mind is that cardioversion is safe in pregnancy. Go ahead and do it. Use the same energy levels as you would in a non-pregnant patient. The current reaching the fetus is really going to be minimal. There have been, when patients have had cardioversions, though, some transient fetal heart rate abnormalities noted. So generally, if you're going to, for instance, cardiovert someone, then who's pregnant, it would be recommended that you do fetal heart rate monitoring during that cardioversion. What about pulmonary hypertension in pregnancy? What's most likely? Maternal mortality does not differ between primary and secondary pulmonary hypertension. Epidural is contraindicated. C-section is the recommended mode of delivery, or nitric oxide can safely be used during LL&D. The answer is D. It can be used safely. Things to understand is that there is high maternal mortality with pulmonary hypertension. It's one of the things we hate to hear in pregnant women. But there is a difference. Those with secondary pulmonary hypertension have a higher mortality rate than those with primary. Vaginal delivery, as with all patients with cardiac disease, generally we reserve C-section for patients who have an obstetric indication, unless the patient is deteriorating significantly because of their cardiac disease. Otherwise, you would prefer vaginal delivery. With labor analgesia, because you don't want this woman in pain and increasing her pulmonary vascular resistance, and these are the patients that you often will need to do invasive monitoring during their delivery. As I said, pulmonary vasodilators can be used in pregnancy, including nitric oxide. At high concentrations, you do have to be a little bit concerned about potential for fetal hemoglobinemia, but that would be for long-term high concentrations. And the thing to keep in mind is that most of the maternal deaths are in the postpartum period due to right ventricular failure, dysrhythmias, and these patients are also higher risk for pulmonary embolism. And then the last slide, so again, I got it done in 50 minutes, cardiac arrest in pregnancy. So you follow the usual ACLS protocols. You use the same drugs in a pregnant patient as in a non-pregnant patient. The two things to keep in mind that are different is that you do need to maintain left uterine displacement. Now, the most recent guidelines tell you that you don't want to actually tilt the bed of the patient because that can interfere with your ability to do adequate chest compressions. So what you should do is someone should be identified as the person who's actually pushing the uterus over rather than tilting the bed. Someone just maintains left uterine displacement while the patient's chest is actually supine. And the other thing to remember is if you have a baby that's viable, then at 4 minutes of ACLS, if you're not making headway, you're not coming back, you need to be proceeding to cesarean delivery to get that baby delivered for two reasons. Number one, it's been shown that survival for the baby is better, but also once you deliver the baby and release that aortocaval compression, resuscitation of the mother is easier, and there are several case reports where ACLS has been unsuccessful. They deliver the baby and right away mom comes back. So you need to be thinking that, and I mean, you do it at the bedside. You don't take the time to run to the OR. If you've got cardiac arrest in the ER or in a labor room, you start ACLS at 4 minutes, you're getting everything ready to do a C-section right there. And so that is lots of topics in a little over 50 minutes. Thank you.